Hello again, everyone. It's my great pleasure to introduce our next keynote speaker, Dr. Wayne Goodman. Wayne Goodman is an MD, DC, and Irene Elwood professor and chair of the Manager Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. He specializes in obsessive compulsive disorder and deep brain stimulation for intractable psychiatric illnesses. He is the principal developer of the Yale-Brown Obsessive Compulsive Scale, which is known as YBox, the gold standard for assessing OCD, and co-founder of International OCD Foundation, the major advocacy group for patients with OCD. He is currently a principal investigator on grants from NIH Brain Initiative, including one on developing adaptive DBS for OCD. Now I'm very much looking forward to his talk.
Thank you so much, Tir, for inviting me. I really do feel honored to be participating. As the title indicates, I'm going to be talking to you about a study we're working on that's funded by NIH Brain Initiative on developing what's referred to as either closed loop or adaptive deep brain stimulation for obsessive compulsive disorder or OCD. These are my disclosures. Jeff Cohen suggested I should give a brief overview of OCD. It may not be that familiar to everyone. The definition is pretty simple. It requires having obsessions and or compulsions. Most patients have both. And the obsessions are recurrent, intrusive ideas, images, or fear that they're going to act on an unwanted impulse. And the compulsions are repetitive, often ritualized behaviors that bear a functional relationship to the obsessions in that they seem designed to neutralize the anxiety or distress associated by the obsessions. And the person feels really driven to perform it, and unless they do, they experience increased distress or anxiety. The symptoms can be very time consuming. Some of the patients we'll be talking about that would be candidates for a neurosurgical intervention like deep brain stimulation will be spending more than 8 hours a day, sometimes 16 hours a day, with maybe just minutes in which they don't have any symptoms. So the disorder can be very impairing. It's relatively common across the globe. Estimated to have a lifetime prevalence of somewhere between 2 and 3%. About half the patients have onset in childhood, and most of the rest have it in early onset in early adulthood. One of the interesting aspects of OCD is that the patients have insight into the irrationality of their thoughts or excessiveness of the behaviors, but still feel driven to carry out the rituals. Otherwise, they experience anxiety, and in some cases they don't want to take a chance that something might happen if they don't carry them out. And patients are often very successful at camouflaging their symptoms from others, including even loved ones, because they're aware that they don't make sense and they might be embarrassing. The picture I'm showing here, this is an artist's rendering of Howard Hughes. Howard Hughes probably is best known as in association with the Howard Hughes Medical Institute, but he was a Texas billionaire and by all accounts suffered from OCD involving contamination, and illustrates one of the paradoxes we see in our patients. What even shows in this illustration, it looks like he was worried about germs and contamination, but infrequently showered or groomed because those compulsions became so involved and time consuming. However, all his executive functionings were well preserved, and that's suggested by the fact that he's still writing out instructions. There were reports that he would keep reading the Wall Street Journal, but it always be delivered in packs of 3. And he would pick the one sandwiched in the middle that had the least human contact. Oops. And let me turn now to the treatment of OCD before I talk to you about the role of deep brain stimulation and why we're conducting this study. About 30 to 40% of patients fail first-line treatments, and those first-line treatments are either a form of cognitive behavioral therapy called exposure response prevention, or the use of serotonin reuptake inhibitors. There are some other pharmacological interventions that seem to work, but there aren't that many options. And so for the patients that are refractory to both behavior therapy and a host of medications, have chronic and severe illness, neurosurgical interventions are a consideration. And in particular, deep brain stimulation targeting an area of the brain referred to as the ventral striatum, sometimes it's also called the nucleus accumbens, has a partial approval from the FDA in the United States for deep brain stimulation. And most data show that about 50 to 60% of patients derive benefit. However, there's room for improvement in clinical outcomes. And there's also a very interesting side effect associated with deep brain stimulation, which is the induction of hypomania that I'll talk about a little bit more. One of the prevailing theory of the neurobiology, of pathophysiology of OCD is that it involves dysfunctional circuits, particularly a cortical striatal thalamocortical circuit that includes areas of the orbitofrontal cortex, anterior cingulate cortex. And the theory has it that there's increased interactions or connectivity, hyperactivity and connectivity between cortical and striatal areas. And that accounts for what becomes really kind of autonomous symptoms that the patient has difficult controlling, even though they have insight into their excessiveness. So how did we get to the use of neurosurgical approaches in OCD? One is the gravity of the illness in some patients, limited number of effective alternative treatments. And then over the last several decades, there have been a case series showing that ablative or lesion therapy interrupting some of the white fiber tracts connecting orbital frontal areas and striatal areas actually was beneficial in reducing symptoms of OCD. And this just illustrates two of the surgical approaches. These are the, again, ablative, not deep brain stimulation approaches. One that has been used frequently, still is to some extent, is called an anterior capsulotomy, in which a small lesion is made in the anterior limb of the internal capsule. In 1999, at which time I was at the University of Florida, a report came out from Belgium by Bart Nutan's group, in which he tried deep brain stimulation, DBS, in 4 patients with severe refractory OCD. And 3 of those 4 patients showed significant improvement. And that improvement was persistent and durable. That led me and others to try to replicate it. I won't tell you the details of it, but I did around that time obtain a grant from NIH in which we conducted a study in 6 patients, and 4 of those 6 patients showed improvement. And then in a follow-up study, those patients at even between 6 and 9 years were still responders. In terms of approval status for deep brain stimulation, most of the work is done in movement disorders. There have been approximately 200,000 cases performed of this procedure worldwide, mostly for Parkinson's disease and tremor. But there is also a partial approval by the FDA for the use of DBS in OCD under what's referred to as the humanitarian device exemption. And again, the types of patients that would be considered for DBS would be severe, and we measure that in part by the Y-box scale. They would have to have more than a 28. The maximum on that scale is a 40. So these would be patients that have certainly more than 8 hours a day are occupied by symptoms, and sometimes almost every waking hour. And they had to have failed multiple treatments. Describe a little bit, for those of you who are not familiar with DBS, this is an illustration of some of the components of deep brain stimulation. In this particular case, electrode is implanted bilaterally. Actually, in this case, it's just unilateral, but the target is the subthalamic nucleus. In the case of OCD, as I mentioned, it's either, it can be actually the subthalamic nucleus as well, although a different region of it than would be used for Parkinson's disease, or in the work that I'll be describing, it would be the nucleus accumbens also referred to as the ventral striatum. These electrodes are implanted permanently. They can be explanted, but generally they're intended to be explanted permanently. The extension wires are tunneled under the skin, and they connect to a device which is sometimes referred to as a brain pacemaker, because it looks a little bit like a cardiac pacemaker and is placed in the chest wall. And you can program that device, and I'll illustrate that in a moment. So this is a typical electrode that would be implanted in the brain. Has 4 contacts. What I do during the programming sessions subsequent to surgery is I can adjust which contacts are actually active. I can change the configuration. I can change the amplitude, pulse width, and frequency of stimulation. And this is showing, this is kind of a stock photo showing what it would be like if you were programming somebody with Parkinson's disease. They have a transceiver over their device. You can communicate with it using a tablet and adjust stimulation parameters. And this is a MRI reconstruction showing a little bit more detail, the location of the electrodes that are implanted for the nucleus accumbens. So the deepest contact is the nucleus accumbens, and the rest of the lead goes down the fibers of the anterior limb of the internal capsule. So we made the argument, and unfortunately it was successful, and at least got us a grant from NIH, that there were limitations to current open loop DBS systems. One of the disadvantages we have in psychiatry, including OCD and doing DBS programming, is we don't have an objective measure like tremor. Mostly I ask about anxiety, mood, and energy. It takes months to optimize settings and multiple visits. And the main thing I look for is what we refer to as a mirth response, the induction of a smile, sometimes laughter. And it is not just a motor response, it's accompanied by mood changes that the person reports feeling happier. And this induction of DBS mirth, if you overshoot, can produce hypomania. And in patients that have never even had a history of hypomania or bipolar illness, if I'm not careful, they can not only feel too happy, but they can have decreased need for sleep. They can have increased spending. You can see impulsive activity that can get them into trouble. They can have speeding tickets. And one of the problems is the tendency then is, if you're inducing that constellation of symptoms, is to turn down stimulation. But then if you turn it down too much, it may no longer be effective in controlling their OCD symptoms or depression. So the solution we came up with was to develop a closed loop or adaptive DBS system. And this requires a new generation of research devices that can only stimulate, but can also record from the brain. And the surgery is being done at Baylor. That's where we're collecting the data. We're also working very closely with Jeff Cohn, Laszlo Jenny, Pittsburgh and Carnegie Mellon, and also with engineers at Brown University. So our goal is to develop a prototype DBS system that can automatically respond to the patient's needs. And from the aims from a machine learning perspective are to build classifiers for decoding the brain signals. In this case, local field potentials that we're recording from the ventral striatum and associating them with different behavioral states, either hypomania or changes in OCD symptoms. And then to develop control algorithms that can automatically adjust stimulation parameters. I'm just gonna, this very complicated slide, just refer to the lower panel. For each patient, we've now implanted 5 patients with these devices. The patient, after having surgery, has 6 months of programming. We try to optimize their clinical response. Then we give them a booster of cognitive behavioral therapy, which seems to work more effectively once DBS is active. And then in order to ensure that these are not sham responders, we do a double-blind discontinuation. And one of the things that we recognized that needed was to identify label for these classifiers that's objective, reliable, and on the same time scale as the brain recordings. And I was fortunate to be able to find Jeff Cohen and his colleagues who had developed automated facial affect recognition system called AFAR. And what we've been doing is time locking or synchronizing the AFAR system with inputs from local field potentials, EEG, ECOG, that's something we haven't done yet. That's our next stage of our study, activity and physiology, as well as changes in DBS programming. And this, I'm sure everybody's familiar with. This is from Laszlo Jenny, showing some of the components of the AFAR system. And I probably don't need to show it to this group. This is our setup in the clinic. One of the nice features, despite COVID, because some of our systems allow recording at home, we've also been doing extensive recordings and time locking of data in the home environment. But this is the setup in the clinic in which we synchronize recordings of AFAR, physiology, local field potentials that we record, scalp EEG. And we look at this during different situations, either DBS programming, during different provocation tasks in which we try to provoke their OCD symptoms, or a social anxiety task. And then we have different tasks that are designed to interrogate different aspects of the putative physiology of OCD. This is, this may surprise some of you, but once we can wake up the patient during surgery and conduct behavioral testing. The brain itself, although it is the organ that provides the experience of pain as well as pleasure, it has no pain fibers itself. So once you anesthetize the scalp, the patient does not experience any pain as you advance the electrodes and do stimulation. And what I'm going to show you here, this is a patient in the operating room in which I turn on stimulation. I'll tell you when I turn off stimulation as well.
Is now.
Oh man.
And you're seeing the AU12 unit.
Describe what you're feeling right now.
I feel happy.
Feel happy. Can you describe that?
I feel happy, like someone just called me and told me that I won a cruise to
I stop stem.
It's a nice place. How do you feel right now?
Not so happy.
So that is a mirth response. It's not usually that dramatic. It's usually a little bit more subtle, usually a smile. And of interest, that usually the smile starts contralateral to the site of stimulation and then rapidly spreads. This next video that I'm going to show you is from our current study. This is a patient during a programming session. And what we have on the top panel, you can see that it shows the status of DBS stimulation either off or different levels of amplitudes of stimulation. And also here in the blue shows positive valence as measured with AFAR. I should mention that generally, although we're capturing individual action units, Jeff has developed a heuristic in which we're converting that to either positive or negative valence affect. At the bottom, you're seeing simultaneous recordings of local field potentials from the brain.
I'm going to start on the left side. And do you want to mark down when by the clock when I make a change? Yeah. What was it like?
It's just like a buzzing in your chest, kind of. That's what it feels like it's rumbling like a motor, but
Yeah.
it's not, you know, I mean, it feels desirable.
Yeah.
It feels like I'm elated, like I'm awake. So it's a good feeling, like positive energy.
Heart rate went up too.
Yeah.
So that was 3.5.
I mean, it's mild, but it's definitely noticeable. Turn it off.
You can tell. You can tell right away.
It stops the vibration.
So that the vibration's right in your chest.
Yeah, but it's hard to explain. So I don't think like anyone else would be able to notice it except for me. You know? Like it's
So you may be getting some vibration in the can. That way. I'll just see how to mitigate that.
it's not disturbing or anything.
You sure? Right.
It's just like I notice it.
Ready?
But that feels good. That feels a little bit more intense. It's like a warm, fuzzy feeling. Like it's good.
Yeah,
It's
yeah.
just good. Yeah. I feel like I could be more engaged in conversation. Actually, I enjoy it. So. Yeah. I like that. Definitely is a little bit more intense than what you had on before. Now it's on.
Exactly right.
Feels good.
Does that feel more intense or
More intense. More intense.
5.5.
I just feel like I got more energy, ready to go. And
Pulse rate's up, but not any more than it was before.
I think I'm acclimating to it.
Yeah.
It's down.
Okay, and I'm going to show you one more very brief video. This is from another subject in our study. And he actually has even more advanced device that allows streaming of the data over air reach of about 3 meters. So he can engage in activities at home, and we can stream the data to a laptop computer that he has there. And what I'm going to show here again is just a little bit later in the course of his programming, I'm going to show, in his case, to a mirth response where I made a change in the pulse width of his stimulation. You can also see heart rate changes on this one as well. And as I mentioned, we've been recording a lot of data at home. We do it under different behavioral conditions, including provocation. And also, as I mentioned, we do exposure response prevention at home, and we can record those sessions and record his local field potential activity during a provocation of symptoms and their treatment. We've also been working with a company called Rune Labs that's developed an app that allows the patient to rate their subjective experience. We've also incorporated an Apple Watch that can measure activity as well as heart rate, and we can integrate all these different inputs. So let me just summarize there. I want to leave room time for questions. We've implanted 5 patients in this first phase of our study. I didn't show you the outcome data, but 2 of our patients have actually been remitters, and that has nothing to do, I can't claim it has anything to do with developing an adaptive DBS system yet. We did have some episodes of hypomania, so that's given us an opportunity to collect data on those behavioral states. We've demonstrated we can record and time lock LFPs, EEG physiology, and AFR together with behavioral tasks and programming, both in the clinic and home. We've collected, actually now it's over 300 hours of LFP data, at home during a wide range of behavioral states. And we're working very hard, as Jeff Batir to process and analyze these data in order to develop our classifiers and control algorithms. And want to thank collaborators across multiple institutions, Baylor, Brown, Pittsburgh, Carnegie Mellon, and also funding from NIH, and also thank Medtronic for donating their devices to allow us to conduct this study.
Yeah, thank you very much, Wayne, for this great talk. Now, let me ask the audience if they have any questions, comments.
So one of the things that that I think is so intriguing is the like why why is it that it's a mirth response? Why why the change in affect, both expressed and on the face and in the voice and the subjective feeling? Why why is it that? Why is it not something else? What is it about this part of the brain that when you stimulate it brings in positive affect?
Well, it's been controversial about how the mechanism of action of DBS has been controversial in general. During the transition from what I described as ablative surgery, where they severed white fiber tracts in a similar region of the brain,
Yeah.
The hypothesis is that they were disconnecting frontal regions from striatum and interrupting this kind of vicious reinforcing loop between obsessions and compulsions. So it was thought that when we turn to DBS, which is delivered at high frequency, about 130 hertz, it was felt that DBS would be functional ablation. It would also interrupt that circuit, kind of cut the wires connecting those two areas. But in fact, what we see instead, and what we've learned too about DBS, is that some large white fiber tracts, myelinated fiber tracts, can actually conduct the DBS stimulation, and it's probably antidromic. Like it's probably it's going backwards into the cortex and then going back into the ventral striatum. But the net effect, we think, is actually increasing activity of the nucleus accumbens and the rest of the reward circuitry. So we're having a direct effect, an immediate effect on reward circuitry.
Right. So many of the subjects, I mean, when they come in, have high levels of depressive symptoms. So are we treating, I mean, is that because of their OCD, or is, and what effects are you seeing on depression?
So the most common comorbid condition with OCD is depression, and usually it seems traceable. It seems secondary to the OCD. And in those cases where you can, whatever treatment you use, the OCD gets better. Usually depression resolves as well. Yeah. In the case of DBS, the immediate and early effects are all on mood and anxiety, reductions in anxiety, improvements in mood. The effects on OCD lag.
Yeah.
The other thing that might be interesting to this audience is I've learned some tricks over the years in terms of how to induce this mirth response, because we try to do this in the operating room, because even though we'll base the targeting on MRIs, structural imaging, tractography, in order to confirm it's the right spot, we'll, as demonstrated earlier, we'll actually test it. And you can miss this response unless you turn it up quickly. So the kinetics, it's not only the amplitude of stimulation, it's the kinetics of it have to be rapid enough in order to induce the smile or mirth response.
Interesting. Have you experimented with that?
Yeah, trial and error, yes. But if you
Yeah.
go, if you ramp up too slowly, you
Yeah.
not see it.
Yeah.
So
Yeah.
what we do, even in the operating room of the programming session, that's why I always go back to off.
Yeah.
I go back to off, wait till we get that
Got it.
baseline, and then I go up quickly.
Okay.
Mhm.
Good.
Yeah, so I have a question about the discontinuation period. So as far as I know, you don't directly turn off the device, but first you lower the amplitude and then lower the amplitude again. Is there a reason why you don't directly turn it off? Or, I mean, will it be too much for the patient, such a change? And second question is, do you observe any difference when the patient comes just after the discontinuation period? So do you experience any lowered positive effects in the patients during?
It's a very good question. And so earlier designs similar to this, we did more abrupt, a complete discontinuation. And what you can see if you do that is what might be interpreted as a withdrawal or rebound phenomena.
Mhm.
So what we decided instead to make it gradual, and also that way we try to keep the patient blinded to the timing of when we're turning down stimulation, because once patients know that you're starting to turn it down, almost universally they feel worse. Just in patients, what we refer to as a nocebo effect. And what we've seen, I didn't show this, the slides here, but one of the patients who was shown in the video, when we did his discontinuation, we did gradual, but once it was completely off, within 24 hours, he said, I just feel too anxious and depressed, and we had to reinstate it. And he did continue to do very well. Another patient, though, it took a while for her to recover her previous status. So it took almost probably a month before we got her back to baseline.
Oh, I see. Interesting. Yeah. And I think it's similar for the case when you turn the DBS on and when you increase the amplitude, right? So for different patients, as I observe, you change the amplitude from 0 to 4 for some of them, but 0 to 2 for some of them, because probably some of them feel anxious even with 2.5 voltage, but some of them just don't notice maybe 4 voltage.
Yes, that's true.
Yeah. So it's like the opposite.
I have a question. Sir, can you hear me?
Yes.
Yeah, yes, me. I have a short question for the home application. For the home, when the patients are at home, from what kind of signals you measure their status? From the physiological signals or video or something?
So the implanted device, which we call implantable neurostimulator, in this case, it's providing stimulation to the ventral striatum, but we can also record local field potentials from adjacent contacts in the same region. And those recordings can be streamed in real time. It's a Bluetooth-like system, just proprietary Bluetooth, can be streamed to another device that receives them.
Okay. So it can be sent to the cloud server.
Well, first we send it to a local computer, and then and you can upload it to the cloud.
Okay, I see. Thank you.
Do we have any other questions, comments? No? Okay, I guess thank you, Wayne, again for this great talk. It was our pleasure to have you here.
Thank you very much, Atir and Jeff.
Thank you.
Thank you. Thank you. Really nice.
Yeah.